Thank you, David. Thank you, everybody. It's a huge honor for me to be here. Dr. Chain has made my job today very difficult because she's raised the bar with her presentation. So I'm going to try to keep up to her standards, but I find that pretty hard to accomplish. Anyways, we are going to repeat some of the slides that she presented, not exactly the same slides, but similar topics because of the relevance of the topics, and also I'm going to be talking about upfront treatment for multiple myeloma, which she did give you a great outline. So these are my disclosures, and here are objectives for this talk. So we're going to be reviewing today patients that are eligible or not eligible for bone marrow transplantation. So by the end of the talk, I do expect that you understand the different nuances between patients that are eligible or not eligible for autologous stem cell transplant. And I also expect that I'll be able to make you a bit more familiar with the different types of treatment strategies for the non-transplant eligible patients, as well as the common side effects that are found with these treatment combinations. So we're going to start by looking at this little mnemonic here, boutique. This is a little recap of the clinical symptoms that Dr. Chain was talking about. So many patients, when they are diagnosed with multiple myeloma, they have at least one of those signs or symptoms there. And we can talk about then bony pain, or patients are out of breath or tired because they have anemia, or they have a lot of tiredness because of the disease burden in itself in their system. They are more predisposed to developing infections, and confusion can be also found as a secondary complication of an infectious process, or sometimes because they have high calcium levels in their blood. So when you have that, then you will do that setup of blood work and x-rays and bone marrow aspirate biopsy that Dr. Chain was talking about. This is usually going to be done by the hematologist, so you were referred from your family doctor, for instance, to a hematologist or an oncologist that are going to request all of those tests. And then after those tests are done, you have a discussion with the hematologist, and he or she can confirm that indeed you have this disease called multiple myeloma. So then what do you do next, right? So what's going to happen to me? That's a big question. So we know that multiple myeloma, as Dr. Chen was mentioning, is a non-curable disease. Many times I like to call it as a chronic disease, such as having high blood pressure, diabetes. You're always going to be needing to monitor it. You're always going to be needing to take medication to keep it under control. But the big thing with multiple myeloma is that it's characterized by a remission and relapsing pattern. So disease is put under control, but it's always going to come back again. And we know from a lot of research that's out there that the longest remission period is the one that comes with the first line of therapy that you take. So really, the first treatment that you're going to be offered has to be the one that's going to give you the best bang to your buck. So it needs to be chosen with a lot of care. So historically, multiple myeloma was a dismal disease. Around 30 years ago, patients would not live for more than 2 or 3 years. Now patients are living roughly 7 to 10 years, and this is a huge advance in life expectancy of this chronic disease. This is basically due to two key developments: the advent of autologous stem cell transplant that may be offered to you, and depending on your disease profile, your doctor may actually offer 2 back-to-back transplants if you're a very high-risk disease, or if you're not receiving autologous stem cell transplant, you may be offered one of several combinations of novel drugs. So we have immunomodulatory drugs, like Dr. Chen was mentioned, also known by IMiDs, the proteasome inhibitors that we call PIs, and monoclonal antibodies that are under study or already approved here in Canada and across the world. So basically, for you to have an idea, the IMiDs are drugs. They're not chemotherapy. They're basically, very simplistically saying, they're going to be sort of waving to your good immune system cells and say, hey, this guy here, this myeloma cell is is a bad guy. Come on over here and attack it. So this is a way that they're going to be working. The PIs are going to impair the metabolism of your myeloma cell in a way that it's going to be impossible for that cell to keep alive, and then the cell is going to die. And then the monoclonal antibodies are they bind into the surface of the myeloma cell, and they're sort of like red flags that will also wave to your immune system and say, hey, come on, attack this guy here. This is not a self cell that's normal. This cell is actually very abnormal, so come and arrest it and kill it. So this is very simplistically the way that these drugs work. And as Dr. Chen was saying, the idea is the combination of drugs, because then you can target different areas in the cell, and that will probably give you a much better success rate in terms of disease control. So the objectives of first-line therapy is to find for you the best combination possible that's going to lead you to the best possible disease control for the longest period of time possible with minimal side effects. Because in myeloma, the better and the longer we are able to keep the disease under control, the strongest will be the likelihood that your life expectancy will be longer. So it's important that we know how to choose and customize the treatment for you, get the best suited treatment for you. So to do this, your physician is going to assess lots of risk factors. So let's go over those. So first we're going to talk about disease-specific risk factors. So as Dr. Chen was mentioning, we have patients with multiple myeloma aggressive features. Those could be poor genetic status. Those could be plasmacytomas, the lumps or tumors of myeloma cells that may develop anywhere in your body. Or you can have what we call plasma cell leukemia. As you know, the plasma cells that are myelomatous cells, they like to stay in the bone marrow. They need, as Dr. Chen was explaining, that bone marrow microenvironment to keep themselves alive. If they're able to be flowing in your bloodstream and they don't care, that means that they are probably very aberrant. And then this type of multiple myeloma is going to be extremely aggressive and difficult to treat. And we also have other high-risk biomarkers that we check in your blood, and those will also give us signals that you have a more aggressive disease, then you have to have a more aggressive type of therapy, very likely. On the contrary, we have the standard risk multiple myeloma patients that will basically be missing any of those 4 risk factors there, and they can have a lighter but still effective type of treatment. So then we also talk about patient-related risk factors. So we know multiple myeloma is a disease of the elderly, but age should not be the major feature of treatment decision. We also have to look into many other factors, and one of them is frailty. So how frail are you? Do you have other chronic diseases such as diabetes, high blood pressure, upfront kidney dysfunction before even you developed your multiple myeloma? Do you already have neuropathy that gives tingling sensation to your hands and feet? Those will be elements to evaluate to decide on the best treatment approach for you. As well as Dr. Chen was saying, distance from the cancer center. If your doctor would think of giving you a treatment that requires you to come on a regular basis to the cancer center, are you able or willing to do this? This is a very important topic. If you're afraid of needles, maybe you don't want to be getting injections under your skin, right? So your preference has to be taken into consideration. And as also Dr. Chen mentioned, drug coverage. Many times we have drugs that are Health Canada approved, but our province is not funding it, and that can be a complicating factor. Your doctor really wants to give you that treatment, but you don't have a private drug plan, or your private drug plan doesn't fund for it, or there's no compassionate supply, although I have to say that the myeloma industry has usually been really, really good in providing free treatment for our patients in many instances. So then finally, we move on to treatment-related risk factors. So we have to assess what's the usual side effect profile of a certain drug or a combination of drugs. Can my patient handle it? How frequent is the treatment given? Does the patient need to come to the cancer center? So those are things that your physician is going to be taking into consideration together with you. Historically in Canada, we divide our patients' first-line treatment options in two groups. So we have branch number one here, that's the transplant-eligible patient, roughly up to 70 years of age and fit, or transplant-ineligible patients, where we have here a lot of options to choose from. So up front here and central, you can see that I'm putting clinical trials. So I'm going to touch on the same topic that Dr. Chen did, and this is because we think that clinical trials are really relevant, and you should not be considered a guinea pig if you're offered a clinical trial, right? This question comes up a lot, and the reason why we like to reinforce the importance of and the relevance of clinical trials is because clinical trials are a great way to make us able to give you upfront drugs that are not available or approved yet. And most importantly, drugs will be only approved by the FDA and by Health Canada if they had been studied in 3 phases clinical trials. So they must have gone through the guinea pig phase, which is the preclinical phase, like we have here that Dr. Chen explained, then the phase 1 trials, then the phase 2 trials, and finally the comparison between the standard of care and the new treatment approach so that they can be approved and later on funded by our provinces. So if you're a suited patient for a clinical trial and your physician offers that to you, don't think you have to do it, but at least consider it. It should be always voluntary, and you can always come out of it if you're not happy for any reason. So I'll leave this here as an important aspect of your treatment schedule, not only for the upfront, but also for the relapse setting, so that you can consider it in the future if you think you need to. So moving forward to standard of care, right? So standard of care. So let's talk about first transplant-eligible patients. So if transplant is offered to you, you're going to think, is transplant a good option for me, or is it not a good option for me? So transplant is a good option for you if you're a younger multiple myeloma patient, roughly around up to 70 years old, if you're fit, if you're active, and or if you have high-risk disease. So transplant is not offered for patients with high-risk disease only. It is the gold standard for patients that are younger and fitter. But if you have high-risk disease, as I said, your physician may offer to you back-to-back transplants that we call tandem transplants. So this is something to consider. Transplant is not a good option for you if you're older, if you're frail, if you have a lot of other chronic disorders that may negatively influence your ability to tolerate the procedure, because it can be quite hardcore, an autologous stem cell transplant. So if you have a very poor heart function or very poor lung function, you may not be suitable for the procedure, even if you would be theoretically indicated to go over the procedure. So pros and cons of transplant. Pros of transplant is that it may be able to keep you for 4 to 5 years without evidence of disease progression. In the upfront setting, you're already surpassing the average, right? Because average life expectancy is between 5-7 years. So we're looking now into 10 years because transplant has improved so much that it is really just at the upfront, you already get 5 years out of the bat. And then this may obviously influence in your overall possibility of life expectancy prolongation. So this is really great. Cons about transplant. So You will have to have a central venous line that we call perm cath, and that's a relatively invasive procedure. You're going to have that antenna hanging there with you for a month or so. But the good news about having that antenna there is that you don't have to be poked every morning when you're in hospital for a blood test. You can receive blood transfusions through that. So it has its ease as well, right? When you have a bone marrow transplantation, you have to be admitted to hospital, and you stay in hospital for roughly 2 to 3 weeks. The first week is usually really boring, but then as you enter the second week, you're feeling really hammered down most of the time, so you feel very tired. You may have nausea, may have vomit, diarrhea, fever. You may need to be on IV broad-spectrum antibiotics. You will likely need to receive blood products, and this can be a limitation for patients that do not want to receive blood products for religious beliefs or for other reasons. So those are things to consider when we're thinking about autologous stem cell transplant in multiple myeloma. Is it a surgery? No, it's not a surgery. We start out the transplant process by offering what we call induction therapy. As Dr. Chen nicely pointed out, the induction therapy is given with a 3-drug regimen called Cy/Bor-D. So Cy for cyclophosphamide, Bor for bortezomib, and D dexamethasone, which is a steroid. You receive back-to-back 4 weekly cycles. So you receive roughly 16 to 24 weeks of treatment, depending on whether you're having 4 or up to 6 cycles of treatment. Why do we need an induction therapy? Why can I not go straight to the transplant procedure? I'm going to explain that to you. Imagine that the bucket here is your bone marrow, and all the rocks are your myeloma cells. So you're full of them when you're diagnosed. Then you do your induction therapy, and what we target is that after the 4 cycles, your bucket is like this. So it's pretty empty now. It still has some cells in there, and then we could stop there theoretically. But if we stop here, chances are that your myeloma will grow back again and much sooner than later. So we want to do that autologous stem cell transplant for consolidation of therapy, hopefully to kill even more cells, or the ones that are not dead, that they stay, sleeping for a long time enough that can keep you free of disease progression for roughly 5 years. So after you receive your cycle of therapy, then the same thing that Dr. Chen explained. So you're going to have your perm cath. You're going to be hooked up to a special machine that's going to collect your stem cells. The stem cells are going to be concentrated and preserved in a special bag. They're going to be frozen in a special freezer, and that's when you're going to be admitted to hospital. So when you go to hospital, the stem cells are not the ones that are going to kill your myeloma cells. They're simply going to repopulate your bone marrow. What's going to kill the remainder of your myeloma cells is the high-dose chemotherapy you're going to receive. It's usually given a drug called melphalan. That's given in very, very high doses. We call it supralethal dose. It's just 1 dose, but that's the single agent in multiple myeloma history that's able to control the disease for such a long period of time, just that 1 drug. But that hammers down your complete bone marrow, right? So all of the other normal cells are not going to be able to survive that drug, and this is when your bone marrow, your stem cells are thawed and infused back to you, just like a blood transfusion. So after that is done, this is all, so these 2, 4 and 5 here, the chemotherapy and the infusion are done within a couple of days. And then you have to stay in hospital so that your doctors can see that your bone marrow is actually going down, give you the medications you need to receive during those first 2 weeks to 3 weeks. Then when you're better in terms of blood cell count, your laboratory work is recovered, you're feeling a bit better, then you'll be able to go home. So after this first phase is done, You already received your high-dose melphalan, you're recovered, and you're home. So you go back to myeloma clinic to see your doctor and follow up, and your doctor is going to consider giving you what we call lenalidomide maintenance therapy. This has been happening over the past, let's say, 5 to 10 years as a standard of care in patients that are eligible for autologous stem cell transplant myeloma. Why do we give lenalidomide maintenance? So lenalidomide is one of the immunomodulatory drugs. It's a pill. We give it in very low doses, and we know from a study that actually evaluated different clinical trials, this is the curve here of the lenalidomide patients, and this is the curve of patients that did not receive lenalidomide maintenance after transplant. So we see in this curve here that patients that received lenalidomide were free of disease progression for almost 53 months, and patients that did not receive it, roughly 2 years without evidence of disease progression. 2 years is good, but 4 to 5 is better. So we use as a standard of care lenalidomide maintenance to all of our transplant patients. Another curve that's important in the same study is the life expectancy curve. Patients that use lenalidomide maintenance have 25% more chances of being alive at 5 years than patients that do not take len maintenance. So this is the standard of care in Canada and around the world right now. What about our transplant-ineligible patients? So transplant-ineligible patients will have a number of potential drug combinations to choose from. So your doctor is going to take into consideration disease-related, treatment-related, and patient-related risk factors. So the choice of therapy is not of your physician only, so it should not be delegated to your physician. It rather is a discussion amongst your physician with you and your close family members if you need to do so. So you look into the overall picture of your disease and your lifestyle, and then you will be able to altogether assess what's the best strategy for you. So here I'm depicting to you the standard of care here for low-risk patients, so lenalidomide and dexamethasone, or MPT, melphalan, prednisone, thalidomide. They are very convenient therapies because they're all oral, so you can take them in the comfort of your home. However, for higher risk patients or for patients that open their clinical picture of myeloma with significant renal impairment, bortezomib-based treatment may be the best option, so your doctor will discuss that with you. The inconvenience of this treatment with bortezomib is that bortezomib is a subcutaneous injection that you take weekly, so you have to come to the cancer center to receive the drug. That cannot be given at home, not even by a CCAC nurse. So this is how the drugs in myeloma work. I'm not going to overwhelm you with this, but this is just really to consolidate the fact that you don't receive one drug only. You usually receive a combination of drugs so that they can target different areas of the myeloma cell so that they can alert your good immune system to this bad cell here to kill it, to disrupt the DNA of the cell, to disrupt the metabolism of the cell, and other components as well. So this is why we always choose combination therapy and not single agent therapy. So let's go over the cycles in themselves very quickly. So let's talk about Lendex to make it easier, right? Lenalidomide and dexamethasone. As I told you, 4 weekly cycles of all oral regimen. Standard dose of lenalidomide is 25 milligrams for 21 days out of that 4-week cycle, but that dose may be lowered depending on your renal function and depending on your frailty. Dexamethasone is a steroid drug, very potent against myeloma cell, and it's also an anti-inflammatory, so if you have bony pain, sometimes not even related to myeloma, sometimes it's related to some arthritis that you may have, That gets better on dexamethasone. Doses can be lowered as well with patients with diabetes or very high blood pressure, because these are one of the side effects of long-term use of steroids in general. Agitation and insomnia, lack of sleep, also present. Those of you who have been on steroids know that you're really wired on your dex days, you don't sleep, and then the following couple of days is going downhill, feeling sad and feeling blue, right? Lenalidomide can cause tiredness, increased risk of blood clots, may bring your blood cell count down. Constipation or diarrhea and tiredness can also happen as one of the most common side effects. VMP is the other gold standard for non-transplant eligible patients. Used to be our only line of therapy for non-transplant eligible patients for many years. We then were approved to have Lendex as well. So VMP is bortezomib, once weekly injection under the skin for 4 weeks. Melphalan, which is a pill that comes in 2 milligram tablets, you will usually need to take a few tablets. That's going to be calculated by your physician, how many tablets you need to take. So you take the tablets every day for 4 days out of a 35-day cycle. Prednisone, also a pill. You usually take a couple of pills, also daily for 4 days, together with your Melphalan. So this treatment here is given for 9 cycles, 9 35-day cycles encompassing roughly 11 months of therapy. After that, your doctor is going to be just monitoring you with occasional follow-ups and blood tests. Common side effects of bortezomib: tingling in the hands or feet, constipation, diarrhea, and a predisposition to shingles. So your doctor will always put you on shingle prevention medication. Melphalan can cause mild nausea, usually very easily taken care of by Gravol 30 minutes before. Rarely patients will throw up with Melphalan. And fever. Fever is an important side effect of any treatment for any cancer. So if there's a fever, hospital right away for you to be assessed to see if you have an important infection, and then be started on IV antibiotics if need be. And prednisone is similar to Dex, so high blood pressure over time may increase your diabetes risk or worsen the diabetes that you already have. So many patients with myeloma have diabetes. They usually need to be on insulin on their steroid days. Agitation and lack of sleep. CyBorD is a variant of VMP. So basically, CyBorD is bortezomib and dexamethasone, but we're substituting the Melphalan to cyclophosphamide. Melphalan and cyclophosphamide are sister drugs. They act on the DNA of the patient, and they will disrupt the DNA of the patient that will lead to cell death. So this drug is also given usually weekly, every 4 weeks, but sometimes we do play around with the way the drug is given so that you can tolerate it better. Bortezomib, as you know, weekly injections, and dexamethasone, doses vary depending on patient's age. Older patients get lower doses because they are as effective of the higher dose in the older patients, but they decrease the risk of infection. So this is important to note. Common side effects, we've gone pretty much around it. So for cyclophosphamide, very similar to Melphalan, mild nausea, vomit, fever, occasional thinning in the hair. None of those will lead to actual hair fall. And MPT. So MPT is the combination of Melphalan and prednisone that we have already gone through, and thalidomide. Thalidomide is the precursor of lenalidomide. So if you remember, thalidomide was the drug given in the 70s to pregnant women, and they had babies with birth defects, especially defects in the arms, and then the drug was banished for many, many years. But it's actually given for treatment of leprosy and treatment of multiple myeloma. We rarely use it nowadays because we have better drugs than thalidomide. Thalidomide is a tablet, but it can cause a lot of side effects. It's similar side effects to lenalidomide, but they're just more. They're more intense. So it's a drug that's relatively difficult for patients to tolerate. So basically in this treatment here, we do melphalan and prednisone together with thalidomide for a year at 4-week cycles. Then we keep the patients on lenalidomide and thalidomide maintenance only for another 2 years. So I'm just going to go over a little bit of evidence here just to show you why we have certain gold standards for first-line therapy as opposed to others. So this is the first trial that compared Lendex with MPT in the upfront treatment of multiple myeloma. So the blue here is the Lendex arm, and this is the progression-free survival, so the time of success of therapy. So we can see here that the curve is much higher here in the Lendex arm compared to the MPT, and that means that patients on Lendex were on average on treatment for roughly 25 months, whereas patients that were on MPT were 21 months. So 4, 5, 6 months can make a difference in somebody's life, right? So this is much better. So we tend to give Lendex as a preference as opposed in comparison to MPT, okay? And this is the VISTA trial. That's the phase 3 trial that brought VMP to the upfront therapy in multiple myeloma. So here, VMP is compared to MP only. So MP is melphalan and prednisone. So we can see that the arm of patients that receive bortezomib is also higher up here in the curve, meaning that they had success on therapy for a longer period of time compared to patients that were on the dual therapy with melphalan and prednisone only. Bortezomib arm, roughly 21 months of disease free of progression, very similar to lenalidomide and dexamethasone. So those two are the two gold standards for upfront treatment in non-transplant eligible patients. And coming in our pipeline in the future, eventually we'll have daratumumab, which is a monoclonal antibody, together with VMP. This is already Health Canada approved. So for patients that are candidates to receive this treatment and have a private drug plan, this may be an option for them. And RVD, which encompasses lenalidomide, bortezomib, and dexamethasone, is already the standard of care for both transplant-eligible and ineligible patients around Europe and the United States, not yet approved in Canada, but under works. So I was just talking to Martine now, and she was telling me that hopefully in a very, very short period of time, we will have news, hopefully about a positive approval of RVD, because RVD really confers a wonderful progression-free survival in non-transplant eligible patients of roughly 36 to 40 months. So it's almost similar to transplant patients. And for transplant patients, patients can have up to 50 months free of disease progression when they use RVD as the induction therapy. So this is really excellent news for the horizon of multiple myeloma therapy in the upfront scale. And I guess that's what I had for you for today. Thank you very much.
Okay, we have some time for questions.
Yes.
Yes. Oh, well, just hang on, please, Susan.
Hi. My question has to do with progression-free survival. What are the defining points? When do you start? The start date, is it the date of your stem cell transplant, the date of diagnosis? What's the start? And how do we define that you are officially out of remission and relapsing?
Right. So progression-free survival is measured as you start therapy. So if you're a transplant-eligible patient, you're usually going to start, it depends. If it's a clinical trial, we're going to be looking into the induction phase, and then we're going to be looking also at the mark of when you actually have your transplant. So you actually look at the whole picture. So since you start in the induction up to when the disease progresses. And disease progression is somehow a relative term because in the past we would consider true progression to start therapy when the patients would develop CRAB symptoms. But for many, many, many years, we're now preferring to treat patients as they start what we call a biochemical progression. So we see that the monoclonal protein or the light chain protein is starting to go up again. So the target of the induction therapy is to ideally have you with no protein or very little protein, ideally 90% or less of the level of protein that you had in the beginning resolved. So it's not there anymore. So you have 10% or less of protein in your bloodstream when you finish your induction therapy, for instance, or during the first 3 or 4 cycles of your treatment for myeloma when you're not going to transplant. So once we attain that, we want to keep that deep response for the longest period of time possible. So then this is why we have most of the time the continuous therapy. But eventually, when I say here 25 months, or when I say here 21 months, we are talking about the protein that was here, but now it's starting to go up. So those are the patients that in the curves of the clinical trials will get out of the clinical trial, so they're censored, or they died because of myeloma or any other cause, so they are also out. So that's why the curves will always start up, because you have 100% of your patients receiving therapy, and then they start relapsing or they die of myeloma or other causes, then the curves will drift down. So when I say that on average patients have 25 months on lenalidomide and dexamethasone, is because 50% of the patients that were in the clinical trial had already relapsed or died before 25 months, and the other 50% moved on. That's another very good question. So relapse, in principle, is if you have an increase in your monoclonal protein of 20% by 2 consecutive times. But we don't really use that, to be honest with you. Because it's true. Because if you have a protein of 1 and it goes to 2, it's a double increase. We don't really care. Right? Because you're doing well, you're doing great. So we want to milk the treatment you're on for the longest time period possible, especially because we're in Canada. And most of the time, you have access to a drug one time. You're not going to be able to access it a second time. Exceptions applied, of course. So we want to milk that treatment. So even if we see that your proteins are slowly going up, we'll keep on monitoring you. We're seeing you every month. Right? So we know where you're going to. So then when we see that the numbers are, okay, it's now really sky high, we might as well stop and start a new therapy before you start to develop CRAB symptoms, right? Or you break another bone, or you come here with a high calcium. So let's start treatment again. So it's very intuitive.
Okay. Yes, sir.
You were saying the average was 5 to 10 years after a cell transplant?
No, that's the average life expectancy of myeloma overall.
Yes.
Yes.
What, if you have a cell transplant and you're high risk, what would the statistics be for that?
Yes. So usually, patients that are high risk have a lower progression-free survival. So they stay free of disease progression roughly around half of the time or less. Many times they will relapse again within a year. So this is why the transplant back-to-back is many times offered. There are studies that suggest that even doing transplant back-to-back is not enough. So you have to do more things like consolidation therapy, which is another modality of treatment after transplant, special different medications for maintenance and not lenalidomide only, always to try to get patients into responding the better. Because in myeloma, high risk does not imply immediate death. Like, for instance, you have a metastatic lung cancer to the brain that you know that that person is not going to be living for years. But in myeloma, high-risk disease has a lot to do with how well is your myeloma going to respond to therapy. So response to therapy is usually way more short-lived than the high-risk patient compared to the patient that's standard risk. And eventually, this will translate into a shorter life expectancy. Yeah.
Yes, Leslie. Just hang on. Please wait for the mic.
Has there been any evidence shown that possibly testing having a second bone marrow test would indicate change in genetic aberrations?
Absolutely.
After treatment?
Yes, absolutely. So we do know that as the disease progresses, we will see newer genetic abnormalities, and this is really why the disease progresses, because the cells that are more aberrant in their genes, they are more aberrant because they are trying to make ways to survive. So if we're giving that cell bortezomib, it will find a way to be resistant to bortezomib so that it can continue to duplicate and multiply itself. So this is done through genetic modifications, genetic mutations. So every time you do a bone marrow, and if you have access to doing tests for the genetics of your myeloma cells, you will see in your FISH or in your next generation sequencing that there will be new aberrations. Yes.
You would recommend then a second bone marrow test at some point in your treatment?
Second bone marrow tests and third bone marrow tests are actually, in principle, the standard of care. So, in principle, as you relapse, a new bone marrow is ideally done. But the truth of the matter is that the bone marrow examination is many times an uncomfortable procedure. Not a lot of patients like to do it. It is somewhat time-consuming, and not always is going to change your physician's decision in terms of treatment option. So not always we will do it, but ideally we should do it.
We have time for one more question. Yes, ma'am. Oh.
Hi. So you mentioned that in the induction therapy, that the goal is to have 10% or less as a response. Why isn't it 0?
There is 0, theoretically, in myeloma. There is 0. So it's 10% or less. So 0 is included. So 0 is what we call, there are several names for 0. Complete hematological response, when you have normalization of the plasma cells in your bone marrow if you repeat a bone marrow. Complete response also means that we see no more protein in your blood. So we do that special test that Dr. Chen showed that's called protein electrophoresis, and then we do immunofixation. If the immunofixation shows no protein, that means 0. So that means you are in complete remission. And then there are fancier tests that nowadays are done in clinical trials only that look into what we call minimal residual disease. So it evaluates very, very small amounts of myeloma cells that are still present in your bone marrow that none of the regular tests that we do, like the protein electrophoresis and immunofixation, would capture. So they can see actually if you are MRD, minimal residual disease negative, so that theoretically means no myeloma
So at the end of the
cells.
4 to 6 weeks then, how come, why wouldn't an option be to extend it to 7 or 8 weeks to try to get it down to 0?
Well, when you do induction therapy, this is why when you do induction therapy, you do 4 to 6 cycles of treatment, and this is really arbitrary to decrease the tumor burden, and then you consolidate with the melphalan high dose. So you do have something else being done. And after that, you still give lenalidomide maintenance. So we're always working towards getting you at 0 or close to 0.
Oh, thanks.
Okay, a tremendous presentation, Dr. Louzada. Thank you so very much.